This is Randy Schell, and I'm making a podcast entitled High Yield Subspecialty Review Cardiac. It's part one of a three-part series on cardiac keywords. Let's look at the cardiac keywords from 2015 listed here. There are topics such as innervation of the heart, echocardiography and diagnosing cardiac tamponade and understanding the aortic valve anatomy, carotid endarterectomy complications, protamine reaction, pacing, factors affecting mixed venous oxygenation, flow volume loops, diastology, myocyte repolarization, congenital heart disease topics, and American College of Cardiology, American Heart Association preoperative evaluation keyword topics. B after the keyword refers to the basic exam. A after the keyword refers to the advanced exam. The gaps in knowledge for 2015 cardiac keyword topics included these two. One, that cardiac drug-eluting stents, if present in a patient, is a contraindication to surgery in a freestanding outpatient surgery center if they've been recently placed. We'll talk about the timing of drug-eluting stents and how to deal with them. And the fact that prazosin is a selective alpha-1 receptor antagonist. There's other keywords from many years, and these will be shown very briefly. If you want to look at them in detail, please stop the podcast and look at these slides. This is from 2014. Of note, a gap in 2014 was the fact that TEE in the mid-esophageal two-chamber view allows imaging of the inferior wall. Actually, you see the anterior wall on one side and inferior wall on the other, and the inferior wall is supplied by the right coronary artery, and therefore a patient with occlusion of the right coronary artery will have changes in wall motion in the inferior wall distribution. Keywords from 2013, 2012, 2011, 2010, and we're going all the way back to 2006. These keywords can help focus your review as you learn cardiac anesthesia topics. But we'll start with coronary anatomy in the electrocardiogram and TEE. Dominant coronary artery, by definition, is the coronary artery that the PDA comes off of, posterior descending coronary artery. If it comes off the right coronary, it's called the right dominant system. If it comes off the left coronary, it's called the left dominant system. Now, some people think of coronary dominance as the coronary artery that supplies the AV node, but the AV nodal artery comes off the right coronary about 90% of the time, off the left coronary about 10% of the time. So you can see why someone with a right coronary artery lesion, thrombosis, ischemia, could have AV block and in a right dominant system. While in a left dominant system and where the left coronary could give off the AV nodal artery, a person with a left circumflex lesion, for example, could have AV block. The LAD supplies the anterior wall, and on the electrocardiogram we see changes across the precordial leads. The circumflex supplies the lateral wall, and we will see lateral electrocardiographic lead changes, 1, AVL, V5, and V6. While the right coronary artery supplies the inferior wall, and inferior electrocardiographic leads include 2, 3, and AVF. And as previously mentioned, acute occlusion of the right coronary artery, when it gives off the AV nodal artery branch, can cause heart block. In the graphic below, we'll look at the picture in the middle first, which is the transgastric mid-papillary short axis with the posterior medial and the anterior lateral papillary muscles shown, as well as the left ventricle, right ventricle. And on the far left here, you can see in green what represents the distribution of the right coronary artery, which is the inferior wall and the part of the septum, while the blue represents the distribution of the LAD, anteroseptal and anterior, and the red represents the circumflex distribution, which is the lateral wall. If you have lesions in those areas, you would expect wall motion changes in the distribution. For example, if the circumflex had acute ischemic episode with thrombosis, for example, the lateral wall may become hypokinetic, akinetic, or even dyskinetic. On the far right shows the transesophageal, mid-esophageal four-chamber view with the left atrium closest to the probe. And when you look at the left ventricular walls, you can see the lateral wall shown here as well as the septum. You're not seeing the anterior wall or the inferior wall. And that moves us towards some TE images and anatomy. Specifically, if you look at the bottom left, you can see the mid-esophageal two-chamber where the anterior wall is to the right and the inferior wall is to the left. An LAD lesion would have wall motion changes in the anterior distribution. RCA lesion would have wall motion changes in the inferior wall distribution. At the top is the mid-esophageal four-chamber view showing the left atrium, the right ventricle, and the left ventricle, mitral valve, and the tricuspid valve. At the top right shows the mid-esophageal bicaval view with the left atrium again closest to the probe, interatrial septum separating the left atrium from the right atrium. But in this view, bicaval, you're seeing the superior vena cava as well as the inferior vena cava. This is an excellent view when placing a pulmonary artery or CVP catheter or wire in the internal jugular down the SVC. You can see the wire coming into the atria or the catheter coming into the atria. And also looking for patent foramenovale. The bottom right shows the mid-esophageal RV inflow-outflow view with the aortic valve cusps and short axis. So we see the right atrium, the tricuspid valve, blood then crosses the tricuspid valve through the RV, out the pulmonary valve, into the pulmonary artery, and you see the aortic valve in the middle with the non-coronary cusp aligning with the interatrial septum, no coronary coming off of there, and the right coronary cusp being the most anterior, and the right coronary would come out of here, and the left coronary cusp would have the left coronary coming off of it. Next topic is coronary blood flow, and the graphic up at the top shows the aortic pressure in orange with systole here, followed by the dicrotic notch closing of the aortic valve, and then diastolic runoff. The important point in blue here shows that the left coronary artery gets most of its blood flow during diastole, as opposed to the right heart, right coronary artery, gets blood flow both during diastole and systole. So most coronary blood flow to the left ventricle during diastole, with the RV during systole and diastole. If we're calculating coronary perfusion pressure, we can do that by taking diastolic blood pressure when the left ventricle is getting most of its blood, minus the pressure inside the heart, which is the LVEDP, and we can try to optimize coronary perfusion by keeping that diastolic blood pressure up, lowering the pressure inside the heart. Nitroglycerin, when we give it, dilates the capacitance vessels, decreases preload, reduces LVEDV and LVEDP, and also is a coronary vasodilator, optimizing coronary perfusion. And another way to optimize coronary perfusion is to lower the heart rate. Beta blockers are good at doing that, not only reducing contractility, oxygen use by the heart, but also lowering the heart rate and giving more time in diastole so that left coronary artery, which is perfused during diastole, and the myocardium gets more blood. A gap in knowledge in 2009 on the in-training exam is shown here. This was published by the ABA. An increase in mean arterial pressure unaccompanied by an increase in diastolic arterial pressure, so systole goes up, diastole doesn't change, would increase right ventricular free wall perfusion more than left ventricular perfusion. Myocardial supply and demand. Demand depends on heart rate, wall tension, and contractility. As heart rate goes up, demand increases. As wall tension increases, demand increases. And as contractility increases, demand will increase. Things that affect supply include the coronary perfusion pressure, which is diastolic blood pressure minus LVEDP. Heart rate, because the slower the heart rate, the more time that's spent in diastole and left ventricle gets perfused. and the left ventricular end diastolic pressure. Keeping that low is important because blood goes from the epicardium to the endocardium through the left ventricle wall, and the subendocardium is the farthest from the epicardial vessels, and is also the vessels there can be compressed by pressures that are high in the left ventricle. So the subendocardium is the part of the heart of the left ventricle that's most at risk for ischemia. The cardiac cycle and electrocardiogram is the next key word, and although this looks like a busy graphic, let's start at the top and go through it. In gray represents the trace of the aortic pressure in systole going up, then the dicrotic notch when aortic valve closes, and then diastolic runoff. In blue represents ventricular pressure, which goes up during systole and goes up a little bit with atrial kick and filling of the left ventricle. In red represents the ventricular volume, which obviously fills some when the AV valve, mitral valve opens and blood flows from atria to ventricle, and then empties a lot when ejection occurs. Then the electrocardiogram and the first and second heart sounds. We want to focus on diastole and the starred events up at the top. First, during diastole is isovolumetric relaxation. And we look at the electrocardiogram while diastole, where it is starting, and you can see at the end of the T wave is the start of diastole, while the end of diastole is the QRS complex. Diastole starts with isovolumetric relaxation, followed by a rapid inflow across the mitral valve from the atria to the ventricle. Passive filling as the left atrium pressure is higher than the left ventricle, the mitral valve opens, filling occurs. Then the pressures equalize and there's a short period of diastasis where we're getting ready for atrial systole, and immediately after that diastasis period, atrial systole occurs, assuming that you're in sinus rhythm. The atria contracts and tops up the left ventricle volume. If you look at these 4 stages of diastole by looking at the flow across the mitral valve with pulse wave Doppler, you get an interesting pattern. And this upper right part of the slide shows pulse wave Doppler. Notice the 2 little slashes here in the pulse wave. And this Doppler is lined up across the mitral valve parallel to the flow. Very important. If this was perpendicular to the flow, it would show no flow at all because you depend upon the Doppler shift to show you some of these changes. And parallel, 0 degrees or up to about 20 degrees, you can get fairly accurate readings. But once you get far off parallel, the accuracy of flow velocities goes down. You see a pattern during diastole. Notice at the end of the T wave, this E followed by nothing, back to baseline, followed by A. E is the passive filling of the left ventricle. The portion between the E and the A wave is diastasis, and then the A wave is atrial contraction. Let's look at pressure volume curves next. And we're going to start at the bottom following diastolic filling of the left ventricle first. So if we look at the y-axis, you can see that it's left ventricular pressure in millimeters of mercury. And on the x-axis, it's left ventricular volume. So it's a pressure volume curve. And if we start where the mitral valve opens and filling of the left ventricle occurs, you can see that in A, as we move along there, the left ventricle is filling, the pressure goes up a little bit, and at the orange M, the mitral valve closes as the ventricle is contracting, and that point right here is end diastole. End diastole when the left ventricle is full, getting ready to contract. If you trace that over to the y-axis, that is LVEDP, or left ventricular end diastolic pressure. As the left ventricle generates a pressure, there's isovolumetric contraction at B, and when the pressure builds up at A, the aortic valve opens. There's ejection at C, and then as ejection occurs, the pressure drops in the aorta and in the left ventricle. There is end systole, and the difference between end diastole minus end systole is stroke volume. So the width of this pressure volume curve is a reflection of stroke volume. And you probably remember that end diastolic volume minus end systolic volume over end diastolic volume is ejection fraction. So looking at the width of this tells us about stroke volume ejection fraction. The height of it tells us about the pressure that's being generated in the left ventricle, and left ventricular end diastolic pressure can be found on the bottom part of this curve at the orange M. LVEDP greater than 18 millimeters of mercury is considered quite high, and that, along with an ejection fraction of 40%, regional wall motion abnormalities, is a reflection of a poor left ventricular function. On the graphic on the left is simply showing LV pressure as it builds up, and at the bottom LV volume, which during end diastole it's full, during end systole it's empty, and the difference between those two is stroke volume. Here's a question for you. Which one of the following medication-related effects is appropriately matched in a patient who's had a recent heart transplant? Heart transplant, you've denervated the heart, cut the vagus nerve, cut the sympathetic nerves. Ephedrine will not cause bradycardia. Phenylephrine will not cause hypotension. Milrinone will not cause hypertension, but esmolol will cause bradycardia. There's still beta receptors present on the heart that will respond to a beta blocker. Next, let's look at cardiac muscle versus pacemaker cells and the action potential. On the left shows the action potential of cardiac muscle. On the right shows an action potential of a pacemaker. Several important points. There's phases of this action potential labeled 0, 1, 2, 3, and 4 in the cardiac muscle here. And you can see that in 0 is a rapid sodium influx, and the charge of the membrane potential becomes positive, and you can see at 1 and 2 you have transient potassium channels open and potassium efflux, and as you have potassium efflux you'd think, well, why doesn't it go back down to below 0 minus? Because calcium comes in, and you can see that in phase 2, calcium coming in and maintaining the positive action potential in the cardiac muscle. And you need that action potential to continue because you want the cardiac muscle to contract and stay contracted to eject the blood. And then in phase 3 you can see the calcium channels actually are closed and potassium continues to go out, and the membrane potential heads back down into the minus range. So that's the action potential of cardiac muscle. Sodium at 0, calcium the main effect at 2, and potassium out at phase 3. And the pacemaker action potential on the right, you can see in phase 0 you have calcium coming in. In phase 3 you have potassium going out, and in phase 4 you have both sodium and calcium coming in. Next topic is cardiac innervation. The picture at the right shows sympathetic nerve innervation of the heart from T1 through T4. The sympathetic nervous system extends from thoracic 1 to approximately L2, so this is upper thoracic region. We call those the cardioaccelerator nerves, T1 through T4. And then the vagus nerve from the parasympathetic nervous system innervates the SA and the AV node. And you can see that the yellow sympathetic nervous system here in this picture is innervating SA node, AV node, and cardiac muscle. There's quite rich innervation of the heart as opposed to the parasympathetic nerve, which is mainly limited to SA and AV node. The vagus nerve releases acetylcholine and causes negative chronotropy, or slowing of the heart rate, negative dromotropy, or conduction through the AV node, and some effects on inotropy, a negative. While the sympathetic nervous system releases norepinephrine, and these cardioaccelerator fibers from T1 through T4, when they release norepinephrine on the heart, cause increased chronotropy, or heart rate, increased dromotropy, or conduction through the node, and increased inotropy via the beta-1 receptor. The denervated heart, the classic example is the heart transplant patient who has lost both sympathetic and vagal innervation when the heart is removed and a new heart is put in. However, the receptors on the muscle of the heart itself are still intact and actually upregulate. They will respond to circulating catecholamines, whether administered exogenously like IV epinephrine or endogenously coming from your adrenal. Atropine and neostigmine, however, are not expected to have the usual effect on heart rate. Atropine given to a patient with a denervated heart where you do not have the vagus nerve innervating will not increase the heart rate, and neostigmine will not cause bradycardia in this denervated heart patient. However, if you had a patient who has had a heart transplant, who you administer neuromuscular blockers to and want to reverse them at the end of a, let's say, non-cardiac surgery, you cannot just give them neostigmine alone, because they would get the other muscarinic side effects other than just bradycardia. They would get bronchoconstriction, etc. And so combining glycopyrrolate with it would still be a wise thing to do. The denervated heart has afferent denervation, the signals from the heart not coming back, and so they're not going to have angina. When you change position, they're not going to have changes in heart rate and blood pressure that normally occur very rapidly. So valsalva, carotid sinus, body position changes, heart rate variability are peripheral autonomic responses that are messed up. Efferent denervation, these patients have an increase in resting heart rate to a resting tachycardia. And I like to think of the sympathetic and the parasympathetic nervous system being the gas pedal and the brake of a car. And we normally have our foot more on the brake, keeping things slowed down. And when you cut both, since there was more on the brake, and you release the brake by cutting the vagus in this case, there's an increase in resting heart rate. And the heart itself will increase its rate more gradually with exertion and slows more gradually with rest, because it's really responding to circulating catecholamines from the adrenal instead of the wiring, the nerves themselves releasing very rapidly norepinephrine in the case of the sympathetic nervous system and increasing heart rate to exertion. Let's talk about some cardiac reflexes next. The first is the baroreceptor reflex. Carotid sinus reflex is when the blood pressure goes up, your body senses it in the carotid sinus, which is present here at the junction and division of the internal and external carotid artery on both sides. It senses this increased blood pressure by stretching the receptors in the carotid sinus, also in the aortic arch, and impulses go to the medulla via cranial nerve 9, the glossopharyngeal, and then back via cranial nerve 10, the vagus, to the heart, causing a slowing of the heart rate. So hypertension results in a decrease in heart rate. And you classically see this when you administer phenylephrine to a patient. As their blood pressure goes up, and before your blood pressure cuff even cycles again, oftentimes on your electrocardiogram you'll see a slowing of the heart rate, which is the carotid sinus reflex sensing the increase in blood pressure and slowing the heart rate. These stretch receptors are activated with hypertension, which leads to decreased sympathetic activity, and the reverse occurs with hypotension. When there's hypotension, there's less activity coming through that nerve, and the heart rate will speed up. This carotid sinus reflex is important during acute blood loss and shock, But if you get very, very low blood pressure, for example, less than 50 millimeters of mercury, it tends to lose its normal functional capacity. And the reflex itself tends to be impaired by volatile anesthetics, propofol, and as previously mentioned, severe hypotension, less than 50 millimeters of mercury. If you're doing a carotid endarterectomy, you see the direct effects of a carotid sinus reflex frequently when a surgeon presses on and around the carotid. As they press on the carotid and press on the carotid sinus, you can get bradycardia, and simply injecting lidocaine around the carotid sinus can anesthetize those nerves and stop the carotid sinus reflex, and then the surgeon can continue without those episodes of annoying bradycardia. Chemoreceptor reflex is next. The chemoreceptor cells in the carotid bodies, they're also in the aortic bodies, but let's focus on the carotid bodies right now. Here they are on the right graphic, kind of in orange, at the division of the external and internal carotid, richly innervated. They respond to changes in mainly P(a)O2, or the partial pressure of oxygen. So they're not responding to SpO2, they're not responding to oxygen content, they're responding to P(a)O2, and a decrease in P(a)O2 in a patient that's not paralyzed, for example, is going to increase their ventilation. Hypoxia results in increased ventilation. When the patient has a P(a)O2 less than 50 millimeters of mercury, plus conditions of acidosis, it makes it even more that the impulses through the cranial nerve 9, specifically to the medulla, results in stimulating respiratory centers to increase their ventilatory drive. So the carotid body responds to P(a)O2, and when it's less than 50, it's really sending maximal impulses through to encourage the patient to increase ventilatory drive. Bilateral carotid endarterectomy has risks. One, if you cut the carotid body innervation on both sides, which occurs during carotid endarterectomy frequently, you would lose the normal ventilatory response, which is hyperventilation, when hypoxia occurs. And if you have a patient with bad COPD who has baseline CO2 retention and has lost some of their CO2 drive, and then you cut the innervation to the carotid body on both sides, they can lose hypoxic drive. Also, when you denervate the carotid body, patients demonstrate exquisite opioid sensitivity, and potential serious respiratory depression with opioids can occur. Now, not only can you denervate the carotid body, but you can denervate the carotid sinus. In the carotid sinus, if you lose its innervation, you're going to lose the normal arterial pressure responses to hypertension. For example, when the blood pressure goes up, normally the heart rate would go down. So blood pressure responsiveness will be messed up. You can also mess up some of the nerves that are near the carotid artery, including the recurrent laryngeal nerve, which if bilaterally injured could cause adduction of the vocal cords stuck in a midline position and a total obstruction of the area. That would be extremely rare. If you cut both bilateral recurrent laryngeal nerves, then you would have the vocal cords flapping just away from midline. You should not have total obstruction, but would lose the ability to vocalize well. Superior laryngeal nerve and hypoglossal nerve also can be injured with bilateral carotid endarterectomy. Cardiac reflex is continued. Bainbridge reflex is another word for the atrial reflex of when the atria is stretched or filled, it increases the heart rate. For example, if you infuse intravenous fluids, which increases the right atrial pressure and stretches the right atrium says, I'm too full, I need to speed up and get rid of some of this volume. That's called the Bainbridge reflex, an increase in heart rate with stretch of the atrium. One of the clinical examples of a Bainbridge reflex was infusing large, fast amounts of intravenous fluids. But another example is if you do a spinal anesthetic and it's quite high, and you get venous capacitance dilation and blood in the venous capacitance vessels pools and right atrial pressure drops, the heart rate via the Bainbridge reflex can decrease. And so young, healthy patients can get severe bradycardia and even arrest with high spinal anesthesia from vasodilation, from knocking out the cardioaccelerators, and from the basically reverse of the Bainbridge reflex, which is a decrease in heart rate when the atrium is underfilled. Basal-Geriche reflex is when you have irritation, for example, of the left ventricle from ischemia. You can get bradycardia and hypotension. Now, the chemoreceptors and mechanoreceptors in the left ventricle sense these noxious ventricular stimuli, and it can be things not just ischemia, could be after revascularization, and vagal afferents will increase the parasympathetic tone. You can get bradycardia and hypotension and coronary artery dilation. And this may be partially a protective reflex. For example, if you get ischemia occurring, obviously bradycardia could be beneficial, producing more time in diastole for coronary perfusion. Here's a question for you again. A valsalva maneuver is performed during echocardiographic determination of a possible patent foramenovale. Which one of the following hemodynamic effects is most likely to occur immediately following release of valsalva? Well, the cardiac output with release of valsalva, you have increased return of blood to the heart, and cardiac output will increase. The systolic blood pressure, as volume returns to the heart as the intrathoracic pressure decreases when you release valsalva, goes up. Right atrial pressure does increase because as intrathoracic pressure decreases, filling of the right side of the heart and eventually left side of the heart increases. And you're going to get a reflex decrease in heart rate. So let's look at that valsalva maneuver in detail next. The valsalva maneuver is forced expiration against a closed glottis. So as you try to force expiration against a closed glottis, you're raising intrathoracic pressure. And as you raise intrathoracic pressure, there is a decrease in venous return to the heart. And if there's less blood in the heart, the cardiac output and blood pressure will decrease. Now, as the blood pressure decreases, this is sensed by baroreceptors, our carotid sinus, for example, and there's a reflex increase in heart rate. When we open the glottis and reduce intrathoracic pressure, suddenly as intrathoracic pressure goes back to normal, venous return goes up dramatically to the heart, and the right-sided filling occurs. And if there's a PFO, the right-sided pressures exceed the left-sided pressures for a short period of time, and you can see right to left transmission of bubbles that are often injected at the same time. And when I say bubbles, I mean a saline contrast study of mixing bubbles and saline between two syringes and injecting them in a vein or a central line. And those agitated saline, small little micro bubbles cross from the right side to the left side across the interatrial septum, showing a PFO in some patients. So the graphic on the right shows the valsalva maneuver, that forcible expiration against a closed glottis. When we do that, you can see that as the mouth pressure goes up, we have pressure against the closed glottis. There's intrathoracic pressure that goes up dramatically. Venous return goes down. Filling of the right and left side goes down. And as filling goes down, look at blood pressure dropping dramatically. And then as you release that pressure, there's sudden filling of the right side and eventually filling of the left side also, and blood pressure comes back up. Cushing's reflex is normally associated with an increased intracranial pressure. When intracranial pressure goes up, the brain says, I need blood flow. ICP being high is limiting blood flow to my head. because MAP minus ICP equals cerebral perfusion pressure. So the body says, I need to increase MAP to maintain my cerebral perfusion. So the blood pressure with an elevation in ICP goes up dramatically. Sympathetic nervous system kicks in, blood pressure goes up, contractility goes up in an attempt to preserve central nervous system perfusion. And you get a reflex decrease in heart rate. So Cushing's reflex is hypertension, bradycardia, usually with increased intracranial pressure being the cause. And the third portion of the Cushing's reflex is some respiratory pattern changes. The last reflex to be talked about is oculocardiac reflex, cranial nerve 5 trigeminal and 10 vagus. Any pressure on the eyeball or stretching of the extraocular muscles can result in bradycardia. And the graphic on the far right shows how this can occur. If, for example, you have a patient who's undergoing strabismus surgery, maybe you're putting a retrobulbar block in and injecting local anesthetic in the back of the eye, pushing on the eyeball, any of those can stimulate the ciliary nerves to the ciliary ganglion, which is represented as CG here, and then to the Gasserian ganglion, which is represented as GG, through the trigeminal nerve to the brainstem, and then back to the heart via the vagus nerve, slowing the heart rate. And in strabismus surgery, it's not uncommon when the surgeons first start to operate and they're stretching the muscles of the eye to see bradycardia. And so the afferents are in the ciliary nerves, go to the ciliary ganglion, the fifth cranial nerve carries it via the Gasserian ganglion, brainstem, then the 10th cranial nerve carries it back, causing bradycardia. This ends part 1 of a 3-part series on cardiac keyword review. Please don't forget to watch part 2 and part 3 also. Here's a quote from Martin Luther King. He said, "Intelligence plus character, that is the goal of true education." Hope you have a wonderful day.